Good evening to everyone and welcome to today's NEET PG mock test. So 2019 NEET, another 6 months to go, and you must be brushing up the high yield topics and getting ready. So from this week onwards, we will have every Sunday afternoon 12 to 2:30 a discussion on the essential questions, at least 100 questions in the 300 paper, which are critical questions. We'll have a review discussion following the mock test. Can the online students can punch whether the voice is loud and clear? Yeah, I'm happy to see 10 plus students watching. Now, what is the valid ground of divorce for the female? Impotence of the male partner or the extramarital affairs of the male partner, unemployment, anything but not infertility. Infertility cannot be ground because the marriage is not on the promise of producing the children certain definitive number in a definitive period. Bite mark, where does it help? It will help to identify the accused, assessment of the height and the type of the teeth the person is having, etc. Now, in the gunshot injury, what are the important key features? Typically, the tissue opening of a gunshot injury will be on the same side as that of the gunshot injury. It will be a radiating wound, there will be a grease collar, there is a gutter injury. So this is how the point where the gunshot is being done, it is on the same side that you have the wound is what you have to basically remember. Now, this is an example of an abrasion collar. Around 20 to 30 questions will be image based questions, so you must be doubly sure that this is how a abrasion collar typically looks like. Perjury, that is falsifying under the oath. What are the true statements about it? It is the section 191 of the IPC that talks about perjury, not the 190 is what you have to be very sure. And the witness can be prosecuted for perjury. He is liable to be prosecuted for perjury is what you have to basically remember. What is corpus delicti? You should remember that it is the body of offense, the essence of the crime, and it includes the body of the victim and the other facts which will help in concluding the cause of the death is what you need to basically remember. What are the various ways by which a crime scene examination can be done? There is a grid method, strip method, wheel method, etc., etc. Basically, when you get into the crime scene, you must think that you have done the crime and you need to walk in the crime scene like that. So what are the various ways of walking? Typically in the strip method, the personnel will walk the path from one end of the crime scene over to the other side of the area and then return in the direction which he has first started. That is called a strip. Similarly, like a wheel, if you happen to walk in the crime scene to imagine how the crime would have been done, that's called wheel method, spiral method, zone method, grid method, line method. I leave the literature for you. With regard to tuberculosis, without a question on tuberculosis, there is no NEET PG, no AIMS exam. So you need to be doubly sure. Among the newly recognized pulmonary TB cases, how many of them are multi-drug resistant TB? It is not 5%, but it is 4.1% are basically the multi-drug resistant tuberculosis is what you have to basically remember. Very nice to see around 16 online students watching. Can you please punch whether the voice is loud and clear? So we are back with our mock tests are very popular since 18 years. for the simple fact that there is not just a test, but there is a discussion which will help you to debate, to fight, to remember certain key points so that it acts like a practice. So a mock test without discussion versus mock test with discussion. With discussion, it is like answering 10 mock tests. So be very sure. So what is the importance of a lepromin test is a very, very important question. As all of you know, that lepromin test is having a epidemiological, is having a prognostic significance. It talks about the immunity status. Lepromin test basically checks the cell-mediated immunity. Unless the person has a intact cell-mediated immunity, the lepromin test may still turn out to be negative, though the person is having the leprosy, and it can differentiate different types of leprosy: borderline, tuberculoid, lepromatous, etc., etc. Now, a leprosy person presented with sural nerve and radial nerve involvement. So, typically lepromatous neuropathy, neural involvement is there. You will treat him like a multibacillary case for about 12 months is considered to be the protocol. So, what is the difference between a histogram versus a bar diagram basically? So, you have the heights and the frequency at which these heights are typically happening. Height is an example of what? It is an example of a continuous data, not a discrete data. Discrete means yes or no kind of answer. Continuous means weight, height, like that, which is having a value. Suppose if pregnancy is there, it's discrete or continuous? It is discrete because there can be no pregnancy or yes pregnancy, but there can't be a slight pregnancy. Whereas height, one can be 10, one can be 5, one can be 3, one can be 2, but some value will be there. Such things are called continuous data. For continuous data frequency, you will be using the histogram, and in the case of the bar charts, they are typically used for the other kind of variables which can be ordinal data or nominal kind of a data set. So what is meant by the PERT technique? Very good. Muhammad Tariq, I'm very happy to see you after a long time. So, PERT technique. I advise all of you to download the UMedico app. There's many more things we are introducing. We are introducing quizzes, betting the quizzes. You can challenge somebody online to join you in a quiz to fight with you, and there will be points, levels of your knowledge in each of the high yield topics, comparative analysis, everything will be available on the UMedico app, which is going to be released next week. So that is the reason I advise you to be on the UMedico app and ask your friends to be on UMedico app, which is going to translate into a betting app on the quizzes on the high yield topics, so that anytime 24/7, if you are feeling bored, you can just open up and randomly identify someone across India, across the world, to fight and challenge and play a game. So that is how the UMedico app is evolving. Now, PERT analysis, program evaluation and review technique. So fundamentally, what is done in this? Whenever you are having a big plan, like you are conducting a college function, you divide that into small goals. First, whom to send invitation, where to get the performers on the stage, then how to get the sponsors. So multiple small activities are created as small goals, and you deliver. So there are two methods: critical path method and PERT. PERT is a probabilistic method, but CPM is called a deterministic model. In a probabilistic model, non-repetitive jobs like planning, scheduling, they are the ones for which you will be using PERT. Whereas repetitive jobs, suppose if you are building a house, any number of houses that you build, it will be the same principle by which you will be building it. So there is a reason there you will use CPM. Then it is based on the events that you calculate the outcome in case of the PUT. Whereas it is based on the activities that you will be judging. The CPM is what you have to basically remember. And PUT is related with activities of uncertain time, whereas CPM is related to those activities which have got a finite time in which they are going to be fulfilled. That's a main difference. Human milk versus cow milk. Last 18 years, this is the same favorite question of the examiner, which you have to be doubly sure. So typically, the iron content, carbohydrate content of the human milk is higher than that of the cow milk. Mother's milk is sweeter because carbohydrate content is higher. Now, what is the definition of serial interval and what is the definition of the incubation period? So, the gap in the time between invasion of infection and appearance of clinical feature is called as the incubation period, not serial interval. Whereas between the onset of the primary case and the secondary case. First, Ramu got cold. Then Ramu's sister Parvati got cold. Then Parvati becomes the secondary case. So between Ramu getting fever and his younger sister later on getting the fever, the time interval is basically called serial interval, which is a measure of the communicability of the disease, is what you need to basically understand. So what are the various tests which are available to check the degree of pasteurization of the milk? Phosphatase test, standard plate test, methylene blue test, not the nitric acid test, they are all considered to be the tests for pasteurization. Can online students can punch in the chat window whether the voice is loud and clear and the transmission is clear? Can you please punch? Yeah. Now, with regard to the Vision 2020, there are certain clinical conditions planned to be controlled by the Vision 2020. So, cataract surgery is performed not at the primary level, it is performed at the district level, is what you have to basically remember. So, cataract, childhood blindness, refractive error, corneal blindness, glaucoma, diabetic retinopathy, trachoma, these are all the conditions which are covered under the Vision 2020 is what you have to basically remember. MedQuest is asking a question, sir, from where to get your notes? Please call our helpline. I am typing here 9000868 is our helpline. She will be able to send you the PDF of the notes of this present discussion. And also, please like our Facebook page, UMedico's Facebook page, and we will be updating a lot of free content on the Facebook. Also, we will upload it into your account in the UMedico app. There are various ways by which you can get the notes. Now, what is this condition? This is nodular episcleritis. So, nodular episcleritis, it can be seen in case of SLE. It takes longer time to resolve compared to the diffuse type of episcleritis. It is more symptomatic and it is painful. That's what you have to basically remember. Now, you are seeing a patient who has muscle weakness, low intelligence quotient, hypersomnia, multiple endocrinopathies. So what is this condition? This is a case of myotonic dystrophy. So in myotonic dystrophy, it is the posterior type of a subcapsular cataract is the most common type, is what you have to basically remember. So how does WHO defines the blindness? It is less than 3/60 is the new definition. inability to count the fingers from a distance of 3 meters, called less than 3 by 60, is called as the blindness, is what need to be remembered. If you use this as a criteria, then it is not 12 million blind, but it is 8 million blind people in India. And what is the ultimate goal by 2020? It is to decrease the prevalence of the blindness to as low as 0.3% is considered to be the important difference. And what is the new name which is being given for the National Program of Control of Blindness? It is called National Program of Control of Blindness, and also visual impairment is what you have to basically understand. Very good. Now, every Sunday 12 p.m. to 2 p.m. we have this Sunday mock test. Whichever the part of the world I am traveling, I still take time to discuss with you the questions and personally frame some of the questions, so that our originality of setting up as much proximate questions as what examiner is looking for, that's our unique selling proposition, USP, that we wanted to offer you, that will you take the 20 tests or 30 tests seriously, think about the 300 questions that you are answering, and definitely you will make a good seat in NEET. It's more of a self-preparation. What we can at most do is to stimulate you. That's what we can be able to do as teachers. Now, this is a classical example of acanthamoeba keratitis, the organism cyst which you are seeing. So it is more common in those who wear the soft contact lens rather than those who are wearing the rigid gas permeable lens, is what you need to remember. It's a painful condition, and it can be cultured on a non-nutrient agar which is enriched with the E. coli, is the classical nature of the acanthamoeba, and it can occur as an opportunistic infection if you are already having herpetic keratitis, is what you need to appreciate. There are different types of lines in ophthalmology formed by the iron deposition. There is a Ferri's line, which is a corneal epithelial iron line. There is a Stoker's line, which is once more a corneal epithelial iron line, which is present at the edge of the pterygium. Then there is a Coates white ring, which is deposited in the Bowman's layer of the cornea. But if you look at the Hudson-Strahl line, it is typically visible. Let's look at Hudson-Strahl line. It is generally located at the junction of the upper 2/3 and the lower 1/3 of the cornea. That is the classical location in case of the keratoconus for the Hudson-Strahl's line. This is an example of a Ferri's line, which is the corneal epithelial iron line, which is there at the edge of a filtering bleb, is what you have to basically remember. And this is a Stoker's line, which is the corneal epithelial iron line at the edge of the pterygium, is what I want to underscore to all of you. Sodium fluorescein angiography versus indocyanine green angiography. What is the main difference? Typically, albumin binding is less in case of sodium fluorescein angiography compared to indocyanine. And in choroidal circulation, the sodium fluorescein can be able to pass freely across the endothelium, is what you have to remember. Now, what is this ocular condition? This is called phthisis bulbi. Whenever there is any injury to the eye, or whenever there is any trauma to the eye, ultimately the eye becomes shrunken, which is typically called phthisis bulbi, and the size of the eye decreases, and calcification occurs into the Bowman's layer, and it needs to be removed by enucleation, especially whenever the phthisis bulbi become painful. Enucleation is considered to be the treatment. Curvilinear capsulorhexis is a way by which you extract the lens. There is another technique called as opener technique. So what is the difference between the two? Typically in the curvilinear, you will give a continuous curvilinear incision. You do hydrodissection, then you will be doing a delineation, then you will be doing a nucleus emulsification, and then finally aspiration. So it has no chances of causing posterior capsular opacification. That's what you need to basically appreciate. This is how typically the curvilinear incision looks like, is what you need to remember. Impaction of the foreign body in the ear. So whenever you are doing the syringing, one important thing you should remember, that for the vegetative foreign bodies you don't do syringing, because the vegetative foreign bodies can swell and can get obstructed, can go deep inside, so you don't do that. Epistaxis. Typically Trotter's method is only for the first aid. Kieselbach is the main source of the epistaxis in 90% of cases. Then if you are leaving the pack in the nose for more than 48 hours, it can breed the infection. And balloon tamponade, you are using pressure. That's the reason it is much more traumatic. Intranasal pack is much more traumatic than the balloon tamponade, is what you need to appreciate. Different types of tympanograms. Which shape of tympanogram is seen in which condition is a favorite topic of the examiner doctor. This is a normal type of tympanogram. Typically it will be peaked in appearance, and flat type, where do you get? It is flat. Whenever there is any non-functioning tube with the middle ear effusion, then you get a flat type. Then if there is any negative pressure, then it will take a dip down, and that is typically seen with a poor Eustachian function, tube function, associated with a serous otitis media type C, is what you typically see. So this is a normal type of a tympanogram. This is how it looks like with a peaking up. Then you have a flat type with a middle ear effusion, impacted wax or a total perforation, and with a negative going down, that is a Eustachian tube dysfunction. That's what you typically come across. What is this red beefy lesion on the tongue classically? There are two things that can cause it. One is geographic tongue is a reddish lesion, and a median rhomboid glossitis also is typically a red lesion, is what you have to basically appreciate. With regard to the wax in the ear, how do you do syringing? Will you hit up or lower wall of the meatus? So you don't hit along the lower wall of the meatus, rather upper wall of the meatus is the one which you will be hitting. Now with regard to the spasmodic dysphonia, spasmodic dysphonia is a neurological issue. There can be hypereduction or abduction. Botulinum toxin is the one which is used. So adductor spasmodic dysphonia, patients will talk with a strained, strangled voice and very harsh. Whereas abductor spasmodic dysphonia, the voice becomes breathy. That's a classical way by which the quality of voice you can decide whether it is adductor or abductor type of spasmodic dysphonia. Now with regard to the child who has a difficulty in swallowing his own saliva, you are able to see the peritonsillar abscess. So there will be a foul breath, hot potato voice, shifting of the uvula to opposite side, and there is a unilateral severe pain. So these are all the features. So what is this lesion protruding out? This is a anthracoinal polyp is what you need to remember. So it starts like an edema, and it comes via the accessory ostium, and it will lead to a unilateral nasal obstruction. They are all the true facts about anthracoinal polyp. There are another 7-8 very high yield points frequently asked in the NEET PG exam about the anthracoinal polyp, which is one of the top hot topics. I am very happy to see 22 plus online viewers. So now, aortic stenosis. Why does the angina occur? Angina doesn't occur because of a fixed blood flow. Why does angina occur? I mean, not to the coronaries. I'll explain you. Typically, the aorta arises from the left ventricle, and coronaries arise at the start of the aorta. Whenever you are exerted, you need to increase your cardiac output. But if there is any fixed aortic stenosis, when you are exercising, the cardiac output doesn't increase commensurately. Because of that, there is a decreased perfusion into the coronaries. So it is not fixed output into the coronaries, but fixed output from the aorta into the aorta is the reason for the development of the exertional angina, which is the very characteristic feature of the aortic stenosis is what you have to basically remember. You have ejection systolic murmur radiating towards the neck, and there can be a left ventricular hypertrophy, and in spite of exercise where you are expecting an increase in cardiac output, that doesn't happen, and that lead to exertional dyspnea, exertional syncope. All events happening with exertion is the hallmark of the aortic stenosis is what you need to remember. Whenever organophosphor poisoning patient comes to you, you will do resuscitation, put him on ventilator, everything is over. But there can be a delayed polyneuropathy which can happen, and that will stop the recovery, and it involves both sensory and motor type of polyneuropathy, and usually why it is called delayed? It takes about 2 to 3 months of time before its onset, hence called delayed is what you need to appreciate. MELD score क्या है? Child puke score क्या है? Child puke score, you have encephalopathy, ascites, bilirubin, albumin, INR, they are the components. Whereas MELD score, you have bilirubin and INR and creatinine. Then MELD sodium means what? Bilirubin, INR, creatinine and sodium. Then you have 5V MELD. That means bilirubin and INR, creatinine, sodium and albumin is called 5V MELD. Now with regard to healthcare facility, hospital associated pneumonia, which pneumonia is treated to be hospital acquired? Unless the patient is there for more than 48 hours admitted, then only that pneumonia is ascribed to be a hospital associated pneumonia. And at least 2 days in the last 90 days, if there was a acute care hospitalization, then only you can accuse the hospital to be associated with that pneumonia of the person is what you need to remember. You have a potato nodes in the chest X-ray, and there are thick lesions, lupus pernio. So this is a case of sarcoidosis. The Schaumann bodies, asteroid bodies may be seen, but they are not pathognomonic of sarcoidosis. You can get hypercalcemia, hypercalciuria, and increased level of angiotensin converting enzyme, etc., etc. Now, transudative Pleural effusion versus exudative pleural effusion. You must know the list of causes. What lead to transitive, what lead to the exudative, and what is the criteria before you call it as Light's criteria of classifying the pleural effusion. This is all very repeatedly, routinely asked a question. If you did wrong, then definitely you need to relook as to how I am going to remember and reproduce in tomorrow's exam the long list of the causes. Very, very important. A 37-year-old has undergone liver biopsy, and typically this kind of chain of lakes appearance is there with sclerosing cholangitis. So this is an example of primary sclerosing cholangitis. It can be associated with inflammatory bowel disease. And periductal fibrosis typically involves the smaller bile ducts. That's what you need to appreciate. Insulinomas, they are encapsulated, they can be found in Men-1 syndrome. What do you find in Men-1 syndrome? Pancreas, pituitary, and all the three central organs. Pituitary, pancreas, and parathyroid, so which are all central organs. So mostly it is single, not multiple. Enucleation is considered to be the treatment of choice, is what need to be remembered. Hypersensitivity pneumonitis has different names. They are not inorganic dust, they are the organic dust is what you have to basically appreciate. And there is an increased amount of CD8 positive T cells in the bronchoalveolar lavage. And very acute severe cases, oral steroids can be tried out for about 3 to 4 weeks. So they are all the true facts. So you can see here the classical hypersensitivity pneumonitis, how it looks like. And farmer's lung, bird fancier's lung, humidifier's lung, moldy hay, etc., etc. So you should be sure on hypersensitivity pneumonitis topic. The mouth is dry, repeated dental caries, and lymphocytic infiltration of salivary glands. What does this remind you? The classical clinical vignette. It reminds you of Sjogren's syndrome. So it is the females who are more frequently affected than the males in case of the Sjogren's syndrome, is what you have to basically remember. There is a lot of lymphocytic infiltration. At one point of time, Sjogren's syndrome patients can have increased incidence of lymphoma. They can have renal involvement. They can develop arthritis. Often there is a confusion whether the arthritis is purely a case of rheumatoid arthritis or is it a Sjogren presenting like that, is always a challenge. So Felties has got neutropenia, not neutrophilia, as all of you know very well. There is a splenomegaly, a long-standing rheumatoid arthritis, etc., etc. as a part of it. In HIV, what do you have? CNS lymphoma, cervical cancer, Kaposi sarcoma. So there are a list of gynecological malignancies recognized to be associated with the AIDS, is what you need to remember. Hypercalcemia is associated with the squamous cell carcinoma, not small cell carcinoma. Also you will find it in breast cancer, prostate cancer, non-small cell cancer. They are all associated with hypercalcemia. One question invariably comes on different types of immunodeficiency syndrome: Job syndrome, Chidiac-Higashi syndrome, severe combined immunodeficiency, etc., etc., which you have to be very sure about. There is an increased risk of infection with pneumocystis jirovecii, and you can give adenosine deaminase. Stem cell transplantation is a part of the treatment. It can be both X-linked recessive or autosomal recessive. They are all the features which are associated with severe combined immunodeficiency. Proximal RTA, which is the type 2 RTA, and the distal RTA, which is the type 1 RTA, you must know all differences. Definitely one question will be asked. So you can go back to our video library. Many times we discussed the topic of Liddle syndrome, Bartter syndrome, Gentleman syndrome, type proximal RTA, distal RTA. So please download Umedico app or visit anatomy2medicine.com. You have got the video library. Many times we discuss in the medicine lectures. So you must know the list. Amphotericin, collagen vascular disease, cirrhosis, nephrocalcinosis, multiple myeloma, type 1. Whereas hereditary causes, sulfonamides, carbonic anhydrase inhibitors, Fanconi's, multiple myeloma, they all can cause proximal RTA. Then diabetes and hypertension, main reason for the type 4 RTA, and chronic interstitial nephritis, aldosterone resistance, they are the causes for the type 4 RTA. You have to be doubly sure. All renal tubular residues are hypokalemic, but not the type 4, which is hyperkalemic, is what you need to basically remember. So I don't go too deep into this because this requires a pen, whiteboard, Ramayana, and we have to start from a long, right from Treta Yuga. We should start discussing Dwapar Yuga, Treta Yuga, abhi Kali Yuga mein hai. 2019 ka NEET PG aa gaya. We had been discussing this topic since 1999. So, favorite topic of the examiner. You require a little bit of analysis, understand the topic. There are small reasons why oxalate stones are more in case of the renal tubular acidosis. Which type of renal tubular acidosis are they more? All these things you have to thoroughly discuss, which is available in the video library. Normal anion gap versus high anion gap metabolic acidosis. Favorite question. Non-anion gap, you find it in renal tubular acidosis, diarrhea, ureterosigmoidoscopy, hyperalimentation, estrozolamide therapy, etc., which you have to basically remember. Now, tubular proteinuria. What are different types of proteinuria, first of all? You have functional proteinuria, which can occur by strenuous exercise, fever, orthostatic proteinuria, thyrotoxicosis, anemia, exercise, etc. Whereas tubular proteinuria, any pathology involving the tubule, like interstitial nephritis. Similarly, any pyelonephrosis or gouty nephropathy or analgesic nephropathy or nephrolithiasis or Fanconi syndrome or heavy metal intoxication, any of them can lead to development of the tubular proteinuria, is what you have to basically remember. What do you see in this duodenal biopsy? You find the atrophy of the villi, which is the classical feature in case of celiac disease. So celiac disease, the oat, rye, barley, they cannot be safely given. It is associated with gliadin, dermatitis herpetiformis, and there is an anti-endomysial antibody, and there is a risk of development of cancer, is what you have to basically remember. Different types of respiratory failure, you have to be doubly sure. Type 1 is there is a hypoxia with a normocapnia. Type 2 is hypoxia with hypercapnia. Then what is type 3? Type 3 is perioperative respiratory failure. Typically, whenever there is any atelectasis of lung, either from a shallow breathing due to the pain or anesthetics or narcotic drugs, that lead to type 3 perioperative. Type 4 is called hypoperfusion respiratory failure. Whenever you are in a cardiogenic, hypovolemic or a septic shock, then hypoperfusion to the respiratory muscles lead to development of a respiratory failure, which is called type 4 respiratory failure, is what you have to be doubly sure about. Which type of porphyria? Photosensitivity is not a feature. Acute intermittent porphyria, correct answer is A. So there is abdominal pain and neuropsychiatric symptoms. Whereas cutaneous tarda, hereditary coproporphyria, variegate porphyria, there is photosensitivity. Similarly, congenital erythropoietic porphyria, protoporphyria also, there is photosensitivity. So you must know the differences between hepatic porphyrias, non-hepatic porphyrias, what enzyme is deficient, what is the clinical presentation, where do you have psychiatric symptoms, where you don't have, everything you have to be doubly sure. So what is fourth heart sound? Fourth heart sound is also called atrial gallop. When the ventricle is getting filled, first one third of the filling of the ventricle is because of the pressure difference, the movement valves open between atrium and ventricle. Second one third due to gravitational pull. Third ventricle atrium actually contracts and pushes the blood into the ventricle. Suppose the ventricle is very stiff, non-compliant because the left ventricular hypertrophy, then atrium has to use a lot of pressure to push the blood into the ventricle, and that lead to fourth heart sound is what you need to remember. So if there is a atrial fibrillation, atria cannot produce fourth heart sound. It is typically correct answer is it is present during the late part of the diastole, not the early part of the diastole, is what you have to basically remember. Last one third of the ventricular diastole during which atrium actually contracts, that time you will listen the fourth heart sound is what I want to underscore to all of you. Now, in the CCG you are finding a sawtooth pattern which is called atrial flutter. Catheter ablation is considered to be a good therapy. It is a narrow complex, not wide complex, narrow complex tachycardia. It is a macro re-entry circuit in the right atrium. Generally, right atrial flutters are common. Sometimes there can be left atrial. And the rate at which atrial flutter occur is at around 300-400. But all those atrial impulses will not go into ventricles because AV node will block it. That's the reason often it is associated with 2:1, 3:1 kind of a AV block is what you have to remember. Now, whenever you are doing treadmill, what type of ST segment changes you call it as positive changes is a very, very important question. So it is the downsloping depression, not upsloping, is considered to be the sign of a positive feature. You can see this is an example of a upsloping type of a ST segment depression. ST segment is depressed, but it is upsloping, which is a benign feature. Whereas here if you see, it is straight descending down. So horizontal ST depression or a down sloping depression. So this is considered to be a positive treadmill is what you have to ultimately remember. So this is an example of a normal ECG, and post stress, how is the ECG ST segment depression? It is a horizontal depression. Is it benign or pathological? It is pathological. You have to worry if there is a horizontal depression or a down sloping depression. If it is a upsloping ST segment depression, then it is considered a benign change is what you need to remember. So how another easy way of remembering is, if it is a down sloping or if it is horizontally depressed down, then he is going into the graveyard. If it is upsloping means he is rising out. So it is benign. That's what you can remember. Acute ischemic stroke, you will be using cerebrovascular accident, you will be using aspirin or a recombinant tissue plasminogen activator is the one which is used in order to manage a acute cerebrovascular stroke is what you need to remember. So what do you have here? Fragmented RBCs, which is a sign of hemolytic process. In hemolysis, there is an increase of unconjugated bilirubin, and since there is no obstruction, that increased bilirubin can go into gut and convert into urobilinogen, and urobilinogen is excreted into the urine. But be careful. Unconjugated bilirubin cannot cross the kidney, hence there is no bilirubin in the urine in hemolytic anemia. But there is an increased amount of urinary urobilinogen. Let me come back to you. A lot of students have confusion on this very important area. I don't want you to have confusion. See, this is liver, doctor. This is your gut. So, whenever the RBCs are broken, you have the bilirubin. which enters into the gut, converted into urobilinogen. Urobilinogen is absorbed back into blood and it will go to the kidney and it is excreted into the urine. So urinary urobilinogen is increased in case of hemolysis. But the bilirubin, some of the increased bilirubin is released into the blood. It is an unconjugated bilirubin. This unconjugated bilirubin, when it reaches kidney, it cannot enter into the, it is not filtered. That's the reason urinary bilirubin is negative, but urobilinogen is positive in case of hemolytic anemia. What happens in case of obstructive jaundice? The bilirubin released is a conjugated bilirubin, because in obstruction jaundice still the conjugation mechanism is intact and that enters into urine. So urinary bilirubin is increased in case of obstructive jaundice. But because of this obstruction, bilirubin cannot enter into the gut. So urobilinogen is not formed. That's the reason the urinary urobilinogen is absent, but increased urinary bilirubin is seen. That is obstructive jaundice. If you find the urobilinogen in the urine, what does it rule out? It rules out the possibility of, if you find urobilinogen in the urine, that means there is no obstruction. Then if you find bilirubin in the urine, that means it is a conjugated hyperbilirubinemia, which is the typical feature of obstruction. So that is how you basically interpret, is what I would like to underscore to all of you. Hope it is very clear for all of you without any confusion. These are all simple concepts, but people carry tremendous confusion. Idiopathic thrombocytopenic purpura in adults can become chronic, not in the case of the children. Coming to the coagulation disorders, Hemophilia B may factor IX deficiency is the challenge, is what you need to remember. So we give an infusion of the factor 9, not factor 8. So plexiform type of a pulmonary hypertension, where do you see, doc? Typically, you find plexiform pulmonary hypertension is familial. Interstitial lung disease due to chronic hypoxemia can lead to pulmonary vasoconstriction and can lead to pulmonary hypoxia. And any congenital heart disease also lead to chronic hypoxia leading to pulmonary vasoconstriction and lead to plexiform pulmonary hypertension, but not with thromboemboli. Whenever there is a child Puig's classification of score C, then it is associated with a very high risk in case of non-hepatic injury surgery. 37-year-old comes with a blurred vision and afferent pupillary defect is there, and after giving methylprednisolone her visual symptoms improved, and she has a pain while moving the eye, and her periventricular demyelinating plaques are seen, called Dawson's figures. So it is clear that she is a case of multiple sclerosis. Spinal cord involvement can very much happen in multiple sclerosis, and it can produce a mass lesion, and it is autoimmune. Oligoclonal bands can be found in the CSF. They are all the facts about the multiple sclerosis which you have to be doubly sure about. Now, what is the safest transplantation approach in case of the liver disease? So transplanting the mesenchymal stem cells from the adipose tissue to liver is considered to be safest of all the options which are being given here. I am trying to run a little faster because you already solved the question paper, the NEET mock test that we have conducted every Sunday morning. That's the reason I'm not going very detailed, and very detailed, it is very difficult to cover the subject in such a short time. The Sunday test is only an indicator as to where you are possibly going wrong, where you need to improve to face the exam. Post-operative ileus, it usually resolves within 48 to 72 hours. And on the radiographs, you will find diffusely dilated bowels. You don't find the adhesions. Adhesions are not the cause of the immediate post-operative ileus. So then about secondary bacterial peritonitis. Appendicular perforation can cause. Polymicrobial, it will be, not one single organism will grow. And marked amount of leukocytosis, complete blood picture only you can decide that it is a secondary bacterial peritonitis, is what you have to remember. This is for the earlier question. In a post-operative ileus, you will find multiple dilated loops of the bowel but no air fluid levels. If air fluid levels are there, then you think of a small intestinal obstruction. But post-operative ileus, typically multiple dilated bowels without the air fluid levels is what you have to appreciate. Now, intestinal ischemia, wherever the blood flow got affected, or if there is an atherosclerosis involving the small blood vessels supplying the mesentery, then intestinal ischemia can occur. So watershed zones between middle colic, left colic, so they are the ones which are affected, and crypts can become hyperproliferative. But if you look at the surface epithelium, it is the surface epithelial atrophy, necrosis, sloughing with a normal or a hyperproliferative crypts, which is considered to be the histopathological hallmark of the intestinal ischemia. One of the favorite questions of the AIIMS PGI question bank, which if you are thinking in exam hall, maybe what is the reason, let me guess, no. You have to be very sure on this single statement. The surface epithelial atrophy, necrosis and sloughing, as what you can see here, with a hyperproliferative crypts or a normal crypts, is the hallmark of the intestinal ischemia, is what you have to basically remember. Colorectal cancer, right side versus left side. What are the differences in the clinical presentation? You have to be very sure about. So weight loss, weakness are the features of right colon. Whereas constipation, alternating bowel patterns, abdominal pain, decreased stool caliber, and rectal bleeding, they are all the features on the left side of the colon, which is in continuity with the rectum, is what you have to remember. And tenesmus is a classical feature in case of the rectal cancer. Continuously patient will feel like going to the washroom, in spite of passing the stool, still he feels that something is not emptied. So that is tenesmus, is a feature of rectal cancer. In thyroid cancer, it is the papillary carcinoma, much more common in the background radiation history. Hurthle cell has got a poor prognosis. Papillary has better prognosis than follicular. And medullary carcinoma is associated with the MEN2B, is what you have to basically remember. So the patient has dysphagia, you are finding a ring-like structure, which is an example of a Skarsky's ring. So dysphagia, in case of the Skarsky, is usually for the solid food which can't pass. And there will be a concentric symmetrical narrowing is the classical feature, and it contains esophageal mucosa above and gastric mucosa below. That of this narrowing is what you see, and it doesn't contain any esophageal muscle. Now in the gastric cancer, you have two varieties, a diffuse type and a intestinal type. So what is the difference between the diffuse type and the intestinal type? Let us look into it. Basically, intestinal type of gastric cancer is very common with H. pylori infection. So nowadays, we are using a lot of triple therapy to eradicate H. pylori. Worldwide, there is an awareness about H. pylori. So the incidence is decreasing. And but overall, if you take diffuse type and intestinal type, intestinal is still more common. So its incidence overall is decreasing because of better treatment of H. pylori. Still, its incidence compared to that of diffuse type, it is much more common. It's more common in the male than in the females, where the male to female ratio is 2:1 in intestinal type, 1:1 in diffuse type. So I leave the literature for you. A young mother brings her 2-year-old son who is having recurrent belly aches, and the baby has been squatting with his knees in his chest, which is causing relief. Classical story of intussusception. So you can see on the radiograph how a intussusceptum looks like, and the typical ultrasound appearance of one going into the other. So it is the Meckel's diverticulum most commonly is the leading point of the intussusception, is the leading point which you should remember for the NEET PG exam. Ileocolic is most common type, and diagnosis is confirmed on abdominal ultrasound, and it can be corrected by giving a air and barium enema, is the way by which you can pull out the intussusceptum, is what you have to remember. This is a favorite question, bhai sahab. If you answered this wrong, you need to seriously drill down and then prepare for exam. Typically, catgut, chromic catgut, polyglycolic, polygalactin, polydioxone, and collagen, they're all considered to be absorbable. Silk, linen, cotton, horse, nylon, polyester, polypropylene, they're all non-absorbable sutures. Coming to surgical site infection, it can very much happen because of an environmental flora that is there in the IOT, in the OT, and the superficial infection, it requires a resurgical exploration of the wound. Coming to perioperative or a preoperative antibiotic prophylaxis, what is the recommendation? Half an hour before surgery is considered to be the classical recommendation. Grade 3 is a contaminated wound where there is a gross fecal material spillage into the wound, is what is called grade 3. So clean wound, clean contaminated, contaminated and infected wound. You must know the various classes. In the testicular cancer, seminomas, they typically metastasize lymphatic spread is more common rather than hematogenous route, is what you have to basically remember. Seminoma is more common than non-seminoma. Cryptorchidism with undescended testis can lead to the development of the seminoma, is what you have to remember. With regard to the obstructive jaundice, so Karvoiser's law typically states, look how is the gallbladder, is it distended or is it shrunken, based on which you can know whether it is cholecystitis or whether it is a pancreatic cancer, is what you have to basically remember in a case of obstructive jaundice. Coming to sepsis, so we don't use any erythropoietin to treat the anemia. After all, it is not the bone marrow depression responsible. SOFA, Q-SOFA, what are the criteria? Respiratory rate, systolic blood pressure, altered GCS, they are the part of the score determination called the Q-SOFA score in case of the sepsis management, is what need to be remembered. In peptic ulcer, early dumping, late dumping, you must know all the differences. Typically, early dumping will have predominantly gastrointestinal symptoms. like abdominal pain, diarrhea, borborygmi, bloating, etc. and vasomotor symptoms like flushing, palpitations, etc. Whereas late dumping is all hypoglycemic symptoms with sympathetic activation leading to perspiration, palpitation, hunger, etc. So early dumping, late dumping differences, post-vagotomy, favorite topic from times immemorial, which you have to be doubly sure. How many types of dressings that you know in surgery? So we have a occlusive dressing, so non-adherent fabrics, absorptive dressing, occlusive dressing, creams, ointments, solutions. There are the various forms of dressing. I leave the literature for you. In absorptive dressing, you use the wide mesh gauge. Not in case of the occlusive dressing is what you have to basically appreciate in this question. I'll leave the literature for you to understand this, a long discussion. Now, which type of nipple discharge? A lot of times patients come with a lot of apprehension to you. Doctor, this nipple discharge, is it benign? Is it malignant? Is it benign? It is malignant. Because lay press reports a lot of writing, and sometimes it is good, but sometimes it can scare the patients. So you must be doubly sure. Physiological is a non-spontaneous bilateral arising from multiple ducts is physiological discharge, nipple discharge. Whereas spontaneous unilateral arising from a single duct is basically considered to be pathological discharge is what you have to basically remember. Coming to the fat necrosis in case of women, you require a biopsy to make a diagnosis. Trauma can be responsible. Now, omphalocele versus gastroscus, you must know the differences. So, the most common congenital anomaly associated is basically the cardiovascular abnormality, not neural tube defect is what need to be remembered. Beckwith-Widman syndrome can be associated with the omphalocele, and I'll leave the literature for you. Omphalocele male to female ratio is 1.5:1, whereas it is equal in gastroscus. So all these differences, which this is one of the high yield topics, omphalocele versus gastroscus. Any entrance you go, it is being asked. There's an abdominal distension in this child, and there is a drooling of the saliva, which is a tracheoesophageal fistula with the esophageal atresia. So now what are the important features? You cannot pass the Ryle's tube because the esophageal atresia. There is a drooling of saliva, and it can be part of the bacterial abnormalities where TE means tracheoesophageal fistula. You have vertebral anomalies, etc., in the bacterial. Now, what you are seeing is a hypospadias. So, typically the chordae, is it on the dorsal or ventral aspect, you must be sure. Epispadias versus hypospadias. It can lead to penile torsion, that is the true statement. Bronchogenic cyst is more often middle mediastinal or sometimes posterior, but not anteromediastinal mass. So what are the 4 A's you need to remember about middle mediastinal mass? A for adenopathy, A for awful primary neoplasm like tracheal or esophageal. Aneurysm, because aorta is in the middle mediastinum, and abnormalities of development. What are the 4 T's for the anteromediastinal mass? T for teratoma, T for terrible lymphoma, T for retrosternal thyroid, and T for thymoma you have to be sure about. So this is how a bronchogenic cyst with the air fluid levels with typically seen arising from the middle mediastinum. Now when the patient is in a comatose stage, head end elevation, not the bed end elevation, is the one which is basically done, which you need to remember. Pyomyitis Pyomyositis, Staphylococcus aureus is the most common organism. PSA is no more considered diagnostic for prostate cancer. If it is more than 10, only it has got a higher amount of specificity but no sensitivity. That is a whole problem with PSA. Patterson-Kelly syndrome, it's more common in the female. A female presenting with nail-shaped, spoon-shaped nails, with dysphagia, echlorohydria, classical clinical vignette about Patterson-Kelly syndrome. Beckwith-Wiedemann, what are all the features? There's a macroglossia, enlarged adrenals, ear creases, omphaloceal, kidney abnormalities, the combination which is called Beckwith-Wiedemann. Coming to the electrocautery, cutting has higher voltage than coagulation is what you have to basically remember. Now, the pain, nausea, vomiting, they're all considered to be the common post-operative symptoms is what you need to remember. Patient is having a pulsating mass lesion. What is this? Aortic aneurysm. So, aortic aneurysm is more common infrarenal, not suprarenal. It can present like a pulsatile abdominal mass, but very commonly elderly people, it is due to atherosclerosis, and patient is asymptomatic, and you may find the presence of an aortic aneurysm if you do an ultrasound in a completely asymptomatic patient. As an incidental finding, you will come across the aortic aneurysm, especially in the elderly people. Atherosclerosis is considered to be the most common cause. So with this, we come to the end of today's review, doctor. And to all the 17 of you who had been watching, many thanks, and we maintain this habit of every week 300 marks grant test with a review and a discussion. And please tell all your friends also to download the UMedico app. In the new version of the UMedico, we are coming up with quizzing, betting. Quizzing, betting. You'll have 10 questions on every high yield topic in each quiz. You can, midnight also you woke up, okay, let me have, who is the guy who is ready to fight with me on lymphoma? So you clicked on the button, then it will search who else is also looking for fighting on the topic of lymphoma. You both can enter into a quiz and the time clock starts, and then you can start answering. End of the game of 10 questions. If you win, you get points, and your level of expertise will increase. You can review those questions later. You can even chat with that guy who fought with you. So that is how Spardhaya Vardhate Vidya. We are introducing the 10 question wala multiple quizzes on high yield topics, and betting with the friends is going to be the new feature in the UMedico app. So getting released on June 15th. So please download the UMedico app and be part of the preparing community of the NEET PG aspirants. Thank you.